Well, hello. My name is Coleen Power, and I am the nurse practitioner in the cardio-oncology program at the Ted Rogers Center for Heart Research and the Peter Munk Cardiac Center at the Toronto General Hospital. I would like to start the presentation by thanking the committee for allowing me this opportunity to speak with you this evening. This is the presentation that I did earlier this year at the Canadian Council of Cardiovascular Nurses conference in Calgary. A brief outline of what I'll be speaking on over the next 30 to 35 minutes. I will start with a couple of definitions pertinent to the practice area, identifying who is at risk for cardiac dysfunction. I will go on to give a description of two patients that we've been following in our clinic over the last 1 to 2 years who have developed cancer therapy-related cardiac dysfunction, and a bit about their different courses of treatments. I chose to focus on the bread and butter of cardio-oncology, which is patients undergoing treatments for breast cancer. There were many different cancers and cancer therapies I could have explained here, but I chose to focus on the larger proportion of patients that we see in our clinic. From there, I will give a bit of an update on a current trial recently launched in our clinic that has sites around the country. I will end on how we tie things together by speaking on the implications for nurses in the clinical setting. I have multiple pictures on this presentation slide, so I hope that they come out okay, but I know some of them may be a bit blurred. Cardio-oncology is a branch of cardiology that cares for patients who are either at risk for or have developed cardiac complications from their cancer therapies. The need for collaboration or blending of cardiology and oncology was first considered in the 1970s when it was discovered that anthracycline-based chemotherapy was associated with the development of heart failure. In recent decades, there have been a significant increase in the number of drugs available for a multitude of cancer types, many of which have cardiac implications. These include molecularly targeted therapies for breast cancer, such as trastuzumab, tyrosine kinase inhibitors, TKIs, for chronic leukemia, or immune checkpoint inhibitors for melanoma, to name a few. Also, radiation to the chest has the potential to promote premature coronary artery disease and valvular heart disease, albeit several years post-therapy. The other reason this is an emerging field is that patients are enjoying a higher survival rate with cancer in recent decades. According to the Canadian Cancer Society, today, about 64% of Canadians diagnosed with cancer will survive at least 5 years after their diagnosis. This is up from 55% in the early 1990s. And in the 1940s, survival was estimated around 25%. Our primary goal in cardio-oncology is to help shepherd patients through their cancer therapies to completion and follow them for some time thereafter. There are multiple common risk factors for both cancer and heart disease, such as diabetes, sedentary lifestyle, obesity, hypertension, and hyperlipidemia. We in cardiology play the supporting role of concentrating on heart disease to allow oncology to focus on the cancer. We don't want patients to survive their cancer only to be left with heart disease. Throughout this presentation, I will use the terms cancer therapy-related cardiac dysfunction as well as cardiotoxicity. Cancer therapy-related cardiac disease is one type of cardiotoxicity. However, it will be the focus of this presentation as it is the significant portion of reason why patients are referred to us and will be featured in the two patients I will later describe. Cancer therapy-related cardiac disease is more focused on left ventricular dysfunction. It is divided into symptomatic and asymptomatic cancer therapy-related cardiac disease. For symptomatic cancer therapy-related cardiac disease, the categories include mild, moderate, severe, and very severe, and their treatments involve no intervention, progressing all the way up to critical care admission for inotropic support and consideration for advanced therapies. For asymptomatic patients, there are categories include mild, moderate, and severe. Mild is where the left ventricular ejection fraction, or LVEF, is greater than or equal to 50%, and a decline in the global longitudinal strain of greater than 15%. Moderate is a new drop in the LVEF of 10% or more to an LVEF of 40 to 49%, and either a 10% drop in the LVEF with increases in cardiac biomarkers such as troponin or NT-proBNP, or a global longitudinal strain drop of 15% or more. And finally, severe asymptomatic left ventricular ejection fraction of less than 40% constitute patients with severe asymptomatic disease. One thing important to mention is the notion of global longitudinal strain, or GLS. GLS is a myocardial deformation analysis of the subendocardial longitudinal oriented fibers. These fibers are most prone to ischemic damage and wall stress and can be a reflection of subtle changes in heart function in the setting of an apparently normal LVEF. The World Alliance Societies of Echocardiography has proposed that normal values for GLS being 17 to 24% for males and 18 to 26% for females. One of the things that must be stressed about this slide is that cardiac risk can be dose-dependent and/or treatment-specific. For anthracycline-based chemotherapy, which is still used widely in multiple cancer treatments, the risk of cancer therapy-related cardiac dysfunction is higher when patients receive a cumulative dose of more than 250 milligrams per meter squared of doxorubicin equivalent chemotherapy. In general, patients receiving treatment for breast cancer typically receive 240 milligrams per meter squared of doxorubicin equivalent. Patients treated for lymphoma, 300 milligrams per meter squared, and patients receiving the highest dose of anthracycline are generally patients with sarcoma who may receive 450 milligrams per meter squared or more. Typically, the max dose of doxorubicin equivalent is 550 milligrams per meter squared. The incidence of drug-induced congestive heart failure at cumulative dose of 300 milligrams per meter squared doxorubicin equivalent is 1 to 2%. And for patients who receive more than 550 milligrams per meter squared of doxorubicin equivalent, the incidence of heart failure is up to 20%. Generally, we don't see a lot of patients receiving this much anthracycline. Patients receiving HER2-targeted therapies, such as trastuzumab, often have previously received anthracycline-based chemotherapy first, thereby increasing their risk of LV dysfunction. We often quote these patients with few other cardiovascular risk factors as having a 3 to 5% risk of LV dysfunction during their therapies. For arrhythmias or conduction abnormalities, the major types of cardiotoxicities include bradycardia, QTc prolongation, atrial fibrillation from taxanes and TKIs. For coronary artery disease, antimetabolites such as fluoropyrimidines and capecitabine, the risk of cardiovascular toxicity is up to 18%. And this includes reversible coronary artery spasm, myocardial ischemia, and coronary artery thrombosis. Alkylating agents such as cisplatin have been associated with hypercholesterolemia, hypertriglyceridemia, hypertension, and insulin-resistant thromboembolic events associated with platelet aggregation and vascular damage. TKIs have been associated with hypertension, with some drugs, such as sunitinib, an incidence of hypertension of up to 47%. The incidence of immune checkpoint inhibitor myocarditis is low, typically 1.14%. However, the mortality is fairly high, up to 40 to 50%. I will apologize in advance for this slide. I know it's a bit busy and a bit hard to read. It summarizes the guidelines for identifying patients at risk for developing cancer therapy-related cardiac dysfunction and other cardiotoxicities quite nicely. In 2022, the first set of guidelines for cardio-oncology were established. This was a joint effort between the Heart Failure Association of the European Society of Cardiology and the International Cardio-Oncology Society. Risk category is established at baseline based on the number of points in minor and/or major cardiovascular risk factors a patient has or their proposed therapies. Minor risk factors include an age of 65 to 79 years, which gives you 2 points, a baseline LVEF of 50 to 54%, which gives you 2 points, and 1 point each for non-anthracycline-based chemotherapy, a BMI of greater than 30, elevated cardiac biomarkers, elevated hemoglobin A1C, a smoking history, and a history of hypertension. Major risk factors include an age of 80 years or more, previous heart failure, valvular disease, or ischemic heart disease, a proposed cumulative dose of anthracyclines of greater than 250 milligrams per meter squared, a very high mean heart dose of radiation, and an LVEF at baseline of less than 50%. A low-risk patient has 1 minor risk factor. Moderate risk patient has 2 to 4 minor risk factors. A high-risk patient has 5 or more minor risk factors, and a very high-risk patient has the presence of any major risk factors. From a radiation perspective, mild, moderate, high, and very high risk is dose-dependent on the administration of a mean heart dose of radiation of less than 5 grays, 5 to 15 grays, 15 to 25 grays, and greater than 25 grays. This value is often not readily available, so for reference, we would use the total dose of radiation. For patients receiving chest radiation for breast cancer, typically they would receive 25 to 40 grays, which is a mean heart dose of approximately 15 to 25 grays. In addition to factoring in the risk score for patients, we do a baseline assessment on all of our patients, and ideally this would be done prior to the start of therapy. We do a standard cardiovascular history and exam, which includes baseline chemistry, lipid profile, biomarkers, echocardiography, and a 12-lead ECG. When I was preparing this presentation, I came across the mnemonic, the ABCDEs, for the prevention of cardiotoxicity, and this could be used for both clinicians and for patients. A is an awareness of your risk factors. B is an awareness of body mass index, or weight, and blood pressure. C is a current smoking history or elevated cholesterol levels. D is diabetes control and prevention, diet, and the dose of chemotherapy and radiation. And E is exercise and echocardiography. In the guidelines, there are surveillance guidelines for most types of cancer therapies. In keeping with the larger proportion of patients that we see in our clinics, I picked one population. Again, patients being treated for breast cancer. For all patients at baseline prior to anthracycline-based chemotherapy, they would receive cardiac consultation, ECG, echo, and cardiac biomarkers. Typically, low and moderate risk patients would also receive biomarkers every second cycle of chemotherapy and an echo after 4 cycles of anthracycline. Typically, patients treated with breast cancer would receive 4 cycles of anthracycline in total. For patients deemed high and very high risk, they would have biomarkers drawn with every cycle of anthracycline and an echo after every second cycle of chemotherapy. All patients, regardless of their risk, would have an echocardiogram 3 months post-treatment and 1 year post-treatment. For patients who have HER2 positive breast cancer and go on to receive trastuzumab for a year, their surveillance protocol is far simpler to remember. Echo and biomarkers are completed every 3 months on all patients. For high-risk patients, echo and biomarkers are also completed 3 months post-treatment and 1 year post-treatment. It is a ministry requirement that patients receive an LV assessment every 3 months as the coverage depends on these assessments. This can vary from clinic to clinic on how this is completed. In our clinic, we do an echo typically every 3 months while they're on trastuzumab. However, many cancer clinics, including our own at Princess Margaret Hospital, often do MUGAs as it is easier to get them done quicker. However, there is the downside of the additional radiation exposure, and also the limitation of the MUGA is that you only receive information on the LVEF and nothing about valvular status. This slide is more of a general view on how to follow patients long-term after any type of potentially cardiotoxic cancer therapy, not just anthracyclines or HER2-targeted therapy based on their risk profile. All patients should have an echo and assessment 12 months post-therapies. For medium-risk patients, it is recommended to follow up to 5 years post-therapy, and for high and very high-risk patients, it is recommended that they be followed annually post-treatment, which has been our practice currently. One of the questions we often get asked in clinic, particularly when we see patients prior to starting their treatment, is if you know that the heart function can be reduced with these cancer therapies, is it not better to start medications to prevent them prior to these complications setting in? This is a very reasonable question. However, there's not a lot of evidence to date to suggest that starting cardioprotective medications has been beneficial. The STOP-CA trial was completed in Boston and published in 2023. Their group looked at prescribing atorvastatin 40 milligrams PO once daily to patients with lymphoma before starting anthracycline-based chemotherapy for up to 12 months to prevent a significant reduction in the LVEF. The primary outcome of the study was looking at the incidence of absolute decline in the LVEF of greater than or equal to 10% from the baseline to a final value of an LVEF of less than 55% over 12 months. The study included 158 men and 142 women, and the median age was 50 years. The results of the study demonstrated that 8.67% of patients in the treatment group or had received atorvastatin met the primary outcome compared to 22% in the placebo group. Overall, there was an odds ratio of 2.9, a significant reduction in the LVEF in the placebo group relative to those in the treatment group. Rather significant findings overall. One medication that is occasionally used in the prevention of anthracycline-induced cancer therapy-related cardiac dysfunction is dexroxane. Part of the reason we don't use this medication very often is that the majority of the patients that we see are under a threshold of cumulative anthracycline dosed chemotherapy that would be considered at high risk for cardiotoxicity. However, for patients receiving large doses of anthracycline-based chemotherapy, and this may include patients with thymomas and sarcomas, they may actually be referred to our clinics in advance in anticipation that they will receive large doses of anthracycline and want to know if they would be a candidate for this medication and if we can follow them during their treatment and sometime thereafter. The mechanism of action of dexroxane appears to reduce the risk of cardiotoxicity seen with anthracycline by fusing with free and bound iron, thereby decreasing the formation of anthracycline iron complexes and reactive oxygen species, which are toxic to cardiac tissue. The indications is that the medication can reduce the incidence and severity of cardiotoxicity associated with doxorubicin administration in patients who have already experienced a partial response or at least maintained stable disease. It should only be used with chemotherapy regimens containing doxorubicin after a cumulative dose of 300 milligrams per meter squared. From here, I will go on to discuss 2 patients treated in our clinic over the last couple of years who have developed cancer therapy-related cardiac dysfunction. These patients are not an exact match, as there is a significant age difference between them, and one of them had previously received cardiotoxic cancer therapies in the remote past. However, I chose to include them as one represents the majority of patients with breast cancer who develop cardiac dysfunction, and the other represents a far less common clinical trajectory from a cardio-oncology perspective. So the first patient is a very lovely 77-year-old patient who was referred to our clinic when there was a note of a decrease in the LVEF. So in terms of her cancer therapy, she was initially diagnosed in 2006 with a localized left-sided breast cancer and received FEC chemotherapy, which is fluorouracil, epirubicin, and cyclophosphamide. The most important one to us is the epirubicin or the anthracycline. Generally, these patients would receive around 200 milligrams per meter squared of doxorubicin equivalent. She got FEC chemotherapy for 6 cycles and then subsequently received 1 year of HER2-targeted therapy. In April of 2023, unfortunately, she was diagnosed again with left-sided breast cancer and underwent surgery. In July of last year, she was unfortunately diagnosed with endometrial cancer as well and had surgery. The pathology from her breast cancer was hormone negative, or I should say ER negative, PR low positive, and HER2 positive. She was treated with 4 cycles of adjuvant carboplatin, paclitaxel, with the last dose of the chemotherapy being in January of this year. The plan was for 1 year or 17 treatments of trastuzumab, which is typically every 3 weeks, and that was started in June of 2023. She was referred to our clinic in December of 2023 when the trastuzumab had to be put on hold because of a decrease in the LVEF. So in terms of her cardiovascular risk factors, she was 77. She had a history of hypertension, diabetes, and dyslipidemia. Her medications at the time of referral to us included candesartan, simvastatin, metformin, pregabalin, and Ozempic. Her echocardiography prior to the start of trastuzumab showed an LVEF that was in the normal range, 50 to 55%, and septal motion abnormalities consistent with the left bundle branch block. In October of 2023, the LVEF was starting to decrease to 45%, and in December, the LVEF had dropped to 40%, and the HER2-targeted therapies were put on hold pending investigation by cardiology. Her symptoms at the time of referral to us in December of 2023 included fatigue and dyspnea with walking short distances. That was not significantly different than what her baseline had been in previous months. We use the same guideline-directed medical therapy for the treatment of cardiac dysfunction as patients with any other type of cardiomyopathy. We try extremely hard to avoid interruptions in treatments or delays in restarting therapy after treatment has been put on hold by hematology oncology. Guideline-directed medical therapy is what we would call cardioprotective medications. This patient was already on candesartan at the time of referral to us. Given her cardiomyopathy, wall motion abnormalities, and multiple cardiovascular risk factors for coronary artery disease, we opted to do a cardiac CT to rule out significant obstructive coronary artery disease. The CT was negative for significant CAD, making us feel that the drop in the LVEF was more associated with her cancer therapies. So in December of 2023, when she was referred to us, the note in the chart was, as long as the LVEF is not below 40%, we recommend continuing with Herceptin therapy along with the optimization of our cardioprotective medications. So we added in bisoprolol, 2.5 milligrams PO once daily, with the plan of up-titrating the beta blocker and adding in an SGLT2 inhibitor in subsequent weeks. The plan was for repeat echocardiogram in approximately 6 weeks' time. Over the winter and early spring, we continued to up-titrate her medications while Herceptin was restarted. However, the oncology team was actually more concerned than we were and held the Herceptin in late February. They wanted to give her a 6-week drug holiday to see if there would be any improvement in the LVEF. Unfortunately, she did not resolve her LVEF. If anything, it may have actually decreased a bit more. A mutual decision by oncology and the patient was made in April not to pursue any more trastuzumab. But this was largely driven by patient preference as well. So at the time, she had received just over half of the prescribed treatments of the Herceptin. Oncology would continue to monitor, as will we. This patient who had to stop her cancer therapies doesn't represent the majority of patients we see in clinic. However, it does go to show the challenges of treating 2 significant medical conditions simultaneously and the difficult decisions patients must face in the time of significant stress and anxiety. Her cancer therapies were ultimately compromised in favor of restoring her heart function. The second patient is more reflective of patients that we would see at the time of referral to us due to a fall in the LVEF. This patient was a fair bit younger. She was 44 years old at the time of referral. So her cancer history, she was diagnosed with left-sided breast cancer, which was hormone negative, HER2 positive, in October of 2021. She completed dose-dense anthracycline-based chemotherapy with a cumulative dose of doxorubicin equivalent of 240 milligrams per meter squared. Dose-dense means that she received anthracycline-based chemotherapy every 2 weeks instead of every 3 weeks. The dose is the same. She was started on paclitaxel and trastuzumab in late January of 2022 and underwent surgery in April of 2022. She also received radiation to the left chest wall and supraclavicular area and internal mammary lymph nodes of 4,000 centigrays in 15 fractions, which was completed in June of 2022. She also had some risk factors. She had a history of type 1 diabetes and dyslipidemia, and at the time of referral to us had just completed her anthracycline-based chemotherapy. Her baseline echo prior to starting chemotherapy was an LVEF of 50%, secondary to regional wall motion abnormalities, and the strain was normal. Prior to receiving Herceptin and post-anthracycline, the LVEF was 54% in January of 2022. In February of 2022, after an admission to hospital for COVID and sepsis, the LVEF had decreased to 47% by 2D LVEF and 46% by three-dimensional LVEF. The strain had also decreased to negative 14.9. So the start of guideline-directed medical therapy was delayed due to the admission for COVID and sepsis. Her symptoms at the time of the diagnosis of cancer therapy-related cardiac dysfunction and referral to us were fatigue with minor chores around the house, 3-pillow orthopnea, which was somewhat multifactorial for rationale, and non-cardiac or atypical chest discomfort. She was started on beta blocker and ACE inhibitor, but wanted to hold off on starting the statin. This was despite her history of type 1 diabetes as well. Overall, with the addition of the cardioprotective medications, we said it was okay to continue to receive the trastuzumab, given that her LVEF was greater than 40%. She also underwent a CT coronary angiogram in June of 2022, which showed somewhat non-significant coronary artery disease and non-obstructive disease with less than 25% stenosis. Her titration of guideline-directed medical therapy and cardioprotective meds was actually limited by hypotension. She completed her treatments in December of 2022, and the LVEF at that time was 50%. We continued to follow her, and in November of 2023, she remained on bisoprolol 5 milligrams p once daily, ramipril 7.5 milligrams once daily, and had agreed over that time to add in a statin of 10 milligrams PO once daily of rosuvastatin. Her echo in January of this year showed an LVEF of 51%, and we were awaiting a cardiac MRI at that time to get a further evaluation of her LVEF, but this was postponed given multiple reconstructive therapies and tissue expanders being in situ, which would be a contraindication to cardiac MRI. Interestingly, within the last couple of weeks, this patient was assessed in clinic, and she was able to have the MRI in late July of this year. And the LVEF was 52%, and the RVEF was 49%. And the plan from both our perspective and the patient's perspective was to continue on her current cardioprotective medications. There was she really had no interest in considering titrating down these medications or coming off them at all. Currently, there's no consensus on the duration of cardioprotective medications after diagnosis of cancer therapy-related cardiac dysfunction, and generally the treatment has been indefinite, as with other cardiomyopathies. This is frequently a question that we are asked in our clinic. Patients often feel fatigued post-cancer therapies, and the beta blockers can only increase these symptoms. Also, patients don't want a reminder a lot of times of what they've been through after their heart function recovers, and many ask if they can actually come off of the cardiac medications. Our group did a retrospective matched cohort study looking at 20 patients with HER2-targeted breast cancer who developed cancer therapy-related cardiac dysfunction. We looked at 10 patients who were weaned off cardioprotective medications and 10 patients who remained on those medications. Patients in the two groups had anywhere from 0 to 3 cardiovascular risk factors. A dose of anthracycline was on average 205 milligrams per meter squared for both groups. The median age in the two groups was 48 to 50 years. The nadir three-dimensional LVEF was 49% in both groups. The total duration of treatment in the stop cardioprotective medication group was 32 months. None in the group required reinitiation of cardiac medications. And most importantly, none developed clinical heart failure, the primary outcome in the 2.5 years of follow-up. The conclusion was that women deemed low risk, stopping cardioprotective medications may be safe. This study served as a pilot study for the STOP-MED trial. The STOP-MED trial is a multi-centered, non-inferiority, randomized control trial of stopping cardiac medications in patients with normalized cancer therapy-related cardiac dysfunction. This is a randomized control trial to assess the safety of stopping heart failure medications in patients with cancer therapy-related cardiac dysfunction and recovered heart function. The primary outcome is that the objective is to compare the proportion of those that develop one or both of the following. 1, left ventricular ejection fraction of less than 50% by cardiac MRI. And 2, new heart failure signs and or symptoms accompanied by elevated cardiac biomarkers in 1 year post-withdrawal of cardioprotective meds. We will enroll asymptomatic patients who have recovered their heart function, who have been off cancer therapies for a minimum of 6 months, and no immediate plans for restarting potentially cardiotoxic cancer therapies. Patients will undergo a cardiac MRI at baseline and at 1 and 5 years, with safety assessments at 6 to 8 weeks, 6 and 9 months, and 3 and 5 years. The investigators will determine if stopping medications is non-inferior to continuing medications by counting the number of patients who develop heart dysfunction 1 year after starting therapy and 1 year continuing therapy. So to conclude this presentation, we must remember there are cardio-oncology guidelines and practices. Therefore, the implications of these recent guidelines and potentially cardiotoxic therapies should be a consideration for both oncology and oncology in our teaching of patients and families. We remember the ABCDEs of risk for cardiotoxicity, have an awareness of the side effects of treatment, know the when, what, and how often to monitor patients, and to improve the chances of treatment success and reduction of symptoms by encouraging physical activity during treatment and beyond. All of these efforts help to guide patients through therapy and prevent a second hit or stressor to the heart into survivorship. Thank you.